A few months ago, a patient came to me genuinely scared. They'd already done the right things. An MRI of the brain, normal. Basic labs, normal. And they were told, good news, nothing serious is going on. But in real life, they were forgetting meetings they used to run flawlessly, losing words mid-sentence, and their spouse even said something along the lines of, you're not quite yourself. So here's the question. How can your medical workup look normal when your brain is clearly slipping? And here's the twist. The real issue wasn't memory in this person's case. It was brain energy, or a deficiency of brain energy. Today, I'm going to walk you through what the standard suspected dementia evaluation does really well, using a terrific mainstream roadmap from American Family Physician, and then I'll show you 5 next level layers that I add for people who want prevention, performance, and longevity. I tore the first page off so you can't see it, but this is the article, the main article that I'm going to be referencing. And stay to the end because you'll know exactly what to ask your doctor and what you can start this week to support brain energy, blood flow, and long-term cognition. So let's get into it. The details are changed for privacy, but this story is real. As always, this video is for educational purposes only and does not constitute medical advice or create a doctor-patient relationship. This patient was a high performer, organized, sharp, reliable. Their identity is tied to being on. The first signs weren't dramatic memory loss. It was performance friction. So rereading the same paragraph multiple times, losing words mid-sentence, needing more notes to do things that used to be automatic, feeling weirdly overwhelmed by simple tasks, and sleep was breaking, i.e. there was waking up around 2 or 3 a.m. And the most important detail is that they were compensating. High performers can hide that cognitive decline for a long time. So they went for the standard workup, a brief cognitive screen, basic labs, basic brain imaging, and then they got that sentence that sounds very reassuring. If that's you, first of all, you're not crazy. Second, don't panic. Now you might ask, what do I need to do? Consider that you need a better map. Now let me be super clear. Mainstream medicine is not the villain here. The AFP article is a very strong, what I would consider a very strong primary care roadmap. It emphasizes validated screen tools like the mini-cog, the MIS, more detailed tests when suspicions remain, like doing the MoCA or the SLUMS. Makes the importance of getting a good history and including an informant history, medication review, full physical and full neurological exam. It encourages labs, although I will say they're very basic labs, and then imaging, which might include non-contrast MRI or CT to rule out secondary causes like brain cancer. And then it emphasizes referral for early onset, severe behavioral issues, or rapid progression, or just an unclear diagnosis. So as you can see on the screen, it's a very good primary care way of dealing with this complaint initially. So that's a great step one. But it's safety medicine. It is important, but that pathway is built to answer, is this dementia, and what dangerous things are we missing? And many of my patients are asking a different question. Why is my brain underperforming before it becomes a diagnosis? So I shift into a systems lens, map cognition into 5 pillars. 1, brain energy, which I would clump metabolism, mitochondrial efficiency, fuel flexibility, glucose, ketones. Number 2, blood flow or vascular health, microcirculation, and endothelial function. Endothelial is like the cells on the inside of the blood vessels. Number 3 would be inflammation and immune system signaling. Number 4 would be sleep and clearance. Sleep being ultimately extremely important. Clearance being talking about lymphatic drainage of the brain, otherwise known as the glymphatic system. And then 5 would be inputs and load management or assessment. So that would be things like hearing, vision, mood, medications, stress. So then we would investigate like detectives, like really good detectives. Now, one reason families feel like diagnosis happens late is because the system waits for measurable impairment. But a lot of people feel that change earlier. That doesn't mean everyone with brain fog has dementia. It means the brain can struggle before it actually fails a test. So your one-page cognitive timeline that I would encourage you to fill out or write down, when did it start? What's the start date? What actually is harder? What makes it worse? What makes those symptoms worse? And what actually improves it? Bring that timeline to your doctor because it's clinical gold. Now you might say, hey, but Dr. Yoshi, isn't this just normal aging? And that's a great question. An American Family Physician says yes. They say that normal aging is occasional word finding difficulty and slower processing, and that what is not normal is progression or losing real life function in work, finances, navigation, judgment, personality. Now, I think that's partially true, but also kind of hogwash. A 90-year-old brain should be as sharp as its 50-year-old self, or even its 25-year-old brain self. Truly, and if it's not, then get evaluated by someone who believes this is so that they don't just blow you off like most doctors will. Super important. I know that this is possible because my own 91-year-old grandmother's memory was sharp as a tack until the day she died or within a week or two of her death at age 91. And same with one of my grandpas. His mind was sharp as a tack until he died at 93. And so again, I know this is possible. The AFP labs are appropriate for primary care. They're a baseline. But for longevity and high performers, normal means not optimized. I'm not saying order everything. I'm saying if the pattern suggests it, you often want earlier focus on vascular and metabolic risk because that's where prevention lies. There's randomized trial evidence that tighter blood pressure control reduced the risk of mild cognitive impairment. That's Sprint Mind Trial, JAMA 2019, which clearly showed that an intensive blood pressure monitoring and improvement definitely decrease the mild cognitive impairment risk. Now, what is high blood pressure? That's a whole nother video because it's not something that's wrong with your heart. It has a lot more to do with your blood vessel wall health and your electrical system inside your body. Now, that's news flash for most people, but that can be for one of my next videos. So for now, we think about insulin resistance trajectory, the brain fuel issues, vascular markers or blood flow issues, inflammation burden, nutrient optimization, and sleep apnea screening if it fits. That's a very important one that is very often missed. And I would say also want to look for pre-sleep apnea or kind of mild or even very, very mild sleep apnea. You don't want, it's a spectrum, right? From super normal sleep breathing all the way to very problematic sleep apnea. Now, you don't get the diagnosis right when it crosses this line. Well, that is the case, but what about this whole gray area here, right? The question is, how do we optimize that? Because you're not broken. You're just trying to keep the brain resilient. Now, this article references the Lancet Commission's 14 modifiable risk factors. Now, this report is a big deal, but you don't need a list. What you need is an order of operations. So my sequencing, sleep first, which includes plenty of high quality sleep, not just the hours you're in bed. Number 2, metabolic and vascular stability, or mitochondrial, insulin, glucose, inflammation, blood vessel cell health. Hearing and vision, mood and stress physiology, and learning how to think about how you think. Number 5 would be social rhythm and cognitive loading. Community is important, and learning an instrument, something new, playing badminton, learning a new language, or just learning in depth about a new subject. And multi-domain prevention isn't just theory. The finger trial, Lancet 2015, showed that a multi-domain intervention for cognition is a classic example that this kind of multi-domain lifestyle approach can preserve cognition in at-risk older adults. And they are doing a watered-down version of what I'm frankly talking about. Now, regarding imaging, MRI is excellent. It's the right tool to rule out tumors, strokes, small brain bleeds, hydrocephalus, which is exactly what the article is aiming for. But the nuance is that function can decline long before actual structural changes look dramatic enough to see them on an MRI or other imaging. So MRI normal can be true, and yet your brain can still be struggling. So that's also why sometimes neuropsych testing, more granular than a quick screen, can be helpful, especially for a high-performance person who compensates. Now, hearing is not a side issue. It's a true brain lever. And this is one of the most underestimated levers. Hearing loss increases cognitive load and can push people into social withdrawal, both of which matter. And we now have randomized trial evidence from the ACHIEVE trial 2024, hearing, intervention, and cognition, that a hearing intervention can slow cognitive decline in certain high-risk older adults. So if you've been meaning to get your hearing checked, this is your sign. And I'll say this plainly, this is what I do. I help people work through this. If you're in that frustrating category of my tests are normal, but I know something's off, and you want a clear prioritized map, there's a link in the description for further clarity. It's free, it's quick, and it's useful. No pressure, just the next step if you want to figure out what to do first. With this client, we didn't find one magical diagnosis. We found a pattern. There was sleep fragmentation issues. There was what I would call as metabolic drift that looked fine until you asked deeper and better questions. There was stress physiology, which was flattening recovery. There was mild hearing strain. And there was medication load, which was adding cognitive drag. So we built a plan with a timeline. The first 1 to 2 weeks, we really worked on sleep anchors, reduced cognitive friction, along with medicine and supplement review. The following, let's say, 2 to 3 weeks, we worked specifically on movement and nutrition strategy aimed at stabilizing brain energy. And then the following 3 to 4 weeks, we really targeted that cognitive loading and sensory support and we stressed downshifting the stress or the interpretation of it. And the wins were real. They reported fewer blank moments, better stamina in meetings, improved word retrieval, and super importantly, the spouse actually said, I feel like you're coming back. So the lesson, the AAFP step 1 is absolutely necessary, but for prevention and optimization, you often need a step 2, a step 3, a step 4, maybe even more, depending on the pattern. So here's what I promised, what to ask your doctor and what you can start this week. So what to ask your doctor, the 6th question. And myself, I like the 6th one the best. But first, number 1, can we review my timeline and real life function, not just a score, because a score doesn't tell about that timeline. Number 2, can we do a medication and supplement review specifically for cognitive side effects, including anticholinergic burden and sedating meds? Be aware that most doctors don't know much about supplements. Number 3, could sleep apnea or sleep fragmentation be contributing? And how do we evaluate that? Because sleep affects brain clearance pathways tremendously, and there's foundational research on sleep and lymphatic clearance. Number 4, would neuropsych testing be appropriate to get a truer baseline? Number 5, given my risk profile, what vascular and or metabolic targets should we tighten up if we were to optimize my situation? That includes blood pressure, glucose, insulin, using functional medicine ranges and trends. It includes lipids, but I'm not talking total cholesterol. I'm talking quality of cholesterol, inflamed cholesterol, other inflammatory markers, because there's absolutely evidence that those vascular targets really make a difference. And then number 6, and this is kind of mind expanding, maybe even beyond functional medicine. But the question is it possible my brain symptoms are related to vascular reserve? Which is how well my brain can increase blood flow under demand. This is where the frontier lens really comes in. Cerebrovascular reactivity, or CVR, is being studied in relation to cognition. It's not routine primary care yet, but it is a powerful framework for certain complex cases. And again, that 6th question changes the frame from, do I have dementia or pre-dementia, or is my brain getting enough fuel and flow, when it needs it. And then, of course, the next steps are how to do further research and analysis and how to actually start and improve those markers. So what you can do this week that are simple and high yield, and I would say just pick two. You don't want to get overwhelmed. If you could change two things consistently over time, that would be dramatic. So a sleep anchor. I'm a huge fan of consistent waking up time. So wake up at the same time every morning, no matter what time you go to bed. And then when you wake up, get morning light. Preferably sunlight, but if you need to do a morning light because maybe you don't have access to beautiful sunrises or sunlight, period, then that can work too. Number two would be move for blood flow. That can include a brisk walk most days. It could include resistance training, even just twice a week. It could include a vigorous type of yoga or a vigorous stretching, or my personal favorite, fascial flow type of workouts. And then number three would be fuel stability. To me, that means a well-sourced, i.e. good for you, protein and fat-forward breakfast and reduced late-night alcohol and or sugar intake. And then number four, schedule a hearing or a vision test if you've been meaning to. And number five, cognitive reserve or a skill block. Set aside 20 minutes a day learning a real skill. Again, that could be a language, it could be a technical skill, it could be an instrument, it could be sign language, it could be learning a new subject, but actually testing yourself because reserve matters over the course of your life. So if you see yourself in this, if you're stuck between normal tests but a not normal life or as high quality as you'd like, you don't have to white knuckle it. If you want help, click the link in the description for further clarity. This is what I do. I help people through this type of scenario step by step. And if you want more case-based detective stories like this, subscribe because my goal is simple. Less fear, more direction, better brain outcomes. Dr. 𝗖𝗎, thank you.